Merci, Jacques. And I would also like to thank Jean-Pierre and the organizers for inviting me to this conference. It is a wonderful place to hold a wonderful conference. Today I'll be talking about transitions from injection drug use to heterosexual HIV epidemics. I would like to acknowledge a large number of coordinators, of collaborators who have worked on this study. Funding from the National Institute of Health, including a specific grant from the Institute of Allergy and Infectious Diseases, and that we have no conflicts of interest. Okay. One of the potential consequences of high levels of HIV infection among injecting drug users is that it may lead to a self-sustained heterosexual epidemic. The great majority of drug users are sexually active, so if HIV reaches high levels in a population of drug users, you have the possibility of sexual transmission to people who do not inject drugs at a level that reaches a critical mass, and heterosexual transmission then takes off on its own. Okay. For this study, we used the UN reference group work to identify locations that had 20% or greater HIV prevalence among injecting drug users. We then plotted the HIV cases. Whoops, wrong button. And we're going the wrong way. Hold on. Okay. We then plotted the cases of HIV or AIDS by year according to risk group, injecting drug users, and heterosexuals. We used a lot of UN and country health department data for this. In terms of transitions from IDU concentrated to heterosexual epidemics, we saw three basic patterns. In some countries, a transition had not occurred, that the cases among IDUs were still greater than cases among heterosexuals. In a second pattern, we saw a high rapid transition where cases among heterosexuals surpassed cases among IDUs within 2 years of peak incidence of cases among IDUs. And the final pattern was a long-term, lower HIV incidence transition occurring 8 to 10 years after the peak incidence among IDUs and at less than 50% of peak incidence among IDUs. Okay, these are the distribution of countries. There was no transition has yet occurred in Russia, Estonia, and Vietnam. High fast incidence transitions occurred in Argentina, Brazil, China, France, Indonesia, the Netherlands, and the Ukraine, and the low, slow transitions have occurred in Italy, New York City, Scotland, and Spain. I want to give some examples of these. This is the data from Estonia, where the cases among IDUs are still greater than cases among heterosexuals. Similarly, in Russia, cases among IDUs are still greater than cases among heterosexuals. Vietnam, similarly. The patterns of the high rapid transition. In Argentina, you can see that cases went up rapidly among IDUs, followed closely by a rapid increase in cases among heterosexuals, so that the transition occurred while cases were still high among IDUs. Similarly, in Brazil, the transition occurred when cases were still high among IDUs. China, France, Although there is some complications in the French data because of HIV among heterosexual immigrants, still the transition was occurring when cases among IDUs were still high. Indonesia, the Netherlands, and Ukraine, where cases among heterosexuals surpassed cases among IDUs, were at a level when IDU cases were still high. In contrast, there are the long-term, low-incidence transitions. You can see that in Italy, cases among IDUs had come down very greatly before they were surpassed by cases among heterosexuals. New York City also, cases among IDUs came down greatly before heterosexual cases were greater than the IDU cases. Scotland, the same pattern, cases among IDUs had come down greatly. And finally, in Spain, the cases among IDUs had come down greatly before they were surpassed by cases among IDUs. Okay. In order to explain these different patterns, we did a systematic literature review on factors that might facilitate transitions from IDU concentrated to sustained heterosexual epidemics. We classified the different values for the countries. In terms of factors facilitating transmission among IDUs, we looked at rapid transmission among injecting drug users, persistent high HIV incidence among injecting drug users, and risky behavior among injecting drug users. In terms of factors that might facilitate transmission from IDUs to heterosexuals, we looked at high prevalence of syphilis, high prevalence of HIV among female injecting drug users, elevated HIV prevalence among commercial sex workers, and high levels of male IDUs utilizing services of female commercial sex workers. And finally, we looked at factors that might facilitate heterosexual transmission in the general population, including elevated rates of syphilis among commercial sex workers and elevated syphilis in the population as a whole. Okay. This is the data for all of the 14 countries. And this slide shows the factors that differentiated the high rapid transitions from the low delayed transitions. The high rapid transitions were much more likely to occur in low and middle income countries versus high income countries, occur in the persistence of high incidence among IDUs, and occur in countries that had high syphilis rates among their IDUs. You note in the low delayed transitions, none of these factors occurred in any of the 4 countries with low delayed transitions. Okay. There are potential interventions to reduce these high rapid transitions. Because most of them are occurring in low and middle income countries, we should think in terms of increased resources, both monetary and technical. We should think in terms of increased political will to address HIV among persons who inject drugs. We should have rapid scale-up of needle syringe exchange programs. These can be scaled up within a period of a few years. They should be user-friendly, encourage secondary exchange, and provide multiple services. Medication-assisted treatment, particularly methadone and buprenorphine, can also be scaled up, though not nearly as rapidly. And we need programs to reduce the initiation into drug injection. One of the least studied aspects of HIV among drug injectors is how do you reduce the number of people who start injecting and are at risk for HIV infection. In terms of additional potential interventions, We should start screening for syphilis and other STIs among injecting drug users. This is well worked in terms of how to screen for syphilis and STIs. We should be considering expedited partner treatment, and we should have large-scale condom distribution. Okay, there are some limitations that I want to mention with respect to this study. We had to use HIV cases or AIDS cases. We had to use the country as a unit of analysis, although epidemics typically occur on a much smaller local scale, but the data is not available. We also were not able to address other HIV transmission modes, such as men who have sex with men, although in most of these countries, injection drug use was the initial driver of the HIV epidemic. Okay. In conclusion, this is the first international study of transitions from IDU concentrated to sustained heterosexual epidemics. We found that transitions have occurred in 11 of the 14 areas with high seroprevalence. We did not find any reverse transitions. Once cases among heterosexuals surpassed cases among IDUs, we never had a reversal where cases among IDUs later surpassed cases among heterosexuals. We found two distinct patterns of transitions. Transition that occurred at a high incidence, very close to the peak of incidence among IDUs, and a pattern of low incidence, slower transitions, typically occurring 8 to 10 years after peak incidence among IDUs. The high rapid transitions were most likely to occur in low middle income countries, in areas with persistent high incidence of HIV among IDUs, and with high rates of syphilis among IDUs. We do have available interventions to reduce these factors, including rapid scale-up of needle syringe exchange programs, programs to reduce initiation into injecting, and screening and treatment for syphilis. Thank you.